Good afternoon. So my talk today is focused on measurement and conceptualization. If you have questions about the context and literature of the research, I'm happy to talk about that after the talk. But basically, life course research on health is really just begun to examine how health inequality is passed along through families. And we understand little beyond that. We know that childhood contexts, such as poverty, are important. And so most research treats health inequality as a process that operates within the span of the individual life course and overlooks the transmission of health inequality across generations within families. And in addition, influences on health likely extend beyond the level of socioeconomic resources that someone has available during a particular segment of the life course to the stability of resources, the timing of changes in resources, and the degree and the direction of that change. And in part, this oversight in current research is related to methodological challenges, as well as the lack of longitudinal data that follow both children and their parents over a substantial portion of their lives. And so one of the main objectives of our ongoing research is to examine the cumulative processes that link socioeconomic status to health over the life course and across generations. And so today I'm going to focus on a piece of the project, one of the first steps really, in which we use an innovative way of conceptualizing and measuring both childhood disadvantage and health as dynamic processes to examine the long-term effects of childhood economic disadvantage on health in midlife in this case. So determining the most appropriate way to examine and test hypotheses about health across the life course is a critical issue that's facing life course researchers. And there's a tension between understanding and describing the pathway that best fits the sample as a whole and an approach that problematizes and tries to examine deviation away from those more normative pathways. And although life course research typically recognizes that health is not static, that it varies over one's life course, most research has really had to rely on measuring childhood experience at one point in time or through static retrospective accounts of childhood circumstances. And this is in spite of the fact that we know that the duration and timing and sequencing of children's exposure to economic hardship during childhood is important for lots of developmental processes and outcomes, such as socioeconomic attainment and in young adulthood and in midlife. And it's, of course, very likely important to health as well. And so the majority of studies also tend to focus on average effects in the models that we use and examine normative patterns that assume a similarity in the pattern of experience over time within subgroups of individuals. And this ignores that most individual trajectories of health, of economic hardship, don't fit a modal pattern. So there's lots of variation around these modal patterns. And so we don't get to see how changes in individual circumstances, like whether childhood conditions are improving or deteriorating, or issues of timing, like whether disadvantages is occurring early or later in childhood, matter. And so the risk here is that our models kind of falsely imply that there's a normative process and an aging effect. And in practice, really, the primary difficulty for life course researchers lies in finding adequate data sources that allow us to make such observations. And so examining disaggregated trajectories, the goal is to problematize heterogeneity within a population. And we can ask how differences in the timing or change of individual experiences are associated with health. And this has been called a person-centered approach because it focuses on conceptualizing and describing individual patterns of stability and change in, say, an outcome like health over time. And for this, you need longitudinal or life history data covering a quite substantial portion of the life course. So we're interested in this analysis, the stratification of what we refer to as health risk trajectories. These are latent variables that reflect the timing and change in the health risks experienced by respondents in midlife. And they're really risk profiles that capture the initial risk of experiencing a health condition and how this risk changes over time. And in addition, we want to distinguish individuals on the basis of their risk of exposure to economic hardship in childhood, in their childhoods, and the timing and stability of this exposure. So we use a disaggregated approach that I'll tell you about in a moment to determine whether or not clear patterns of economic hardship in childhood and distinct trajectories of health risk in midlife are actually present in the data. So that was our first step, is to see, can we even identify distinct patterns of economic hardship and trajectories of health risk. And in the next step, our goal was to examine whether health risk trajectories in adulthood differed according to the patterns of childhood economic hardship. So to do this, we used repeated measures latent class analysis. It's an application, an extension of latent class analysis, and it detects associations among variables due to an unmeasured latent source of variation, and it sorts individuals into mutually exclusive and exhaustive latent classes. And RMLCA doesn't assume that individual change follows a functional form with respect to time. So many models, like growth curve models, assume you have to specify a functional form with respect to time. And instead, with these latent class models, the estimated latent classes represent differing patterns of change in the outcome across time points. And I'll show you an example of this in just a moment. So the data set that we used for this project is the US panel study of income dynamics. And it's an ongoing, nationally representative sample of about 5,000 families. And the PSID began in 1968. And the latest wave of data that was available at the time when we conducted this analysis was collected in 2009. And what's unique and really advantageous to us about the PSID is that when children of PSID families leave their parents' home, they become PSID family units as well, if they choose to continue on in the survey. And this split-off sample has been examined over time and been found to be representative as well. And so we have this multi-generational design and a long span of data collection. And this allows us to link adult children back to their parents and basically look back in time to a point when parents were actually reporting on the socioeconomic environment that the children were in when they were in the parental home. And so in using this feature of the PSID, we were able to avoid problems with recall bias in childhood conditions, and then also make use of prospective longitudinal data. And so for this analysis, we focused on adult children who were newborn to 8 years old in 1968. So they're a portion of the baby boom cohorts. In the latest wave in 2009, they're 42 to 49 years old, and so they're entering a stage of life where many chronic conditions begin to emerge. And so first, we used RMLCA to identify subgroups of individuals with similarities in their experience of economic hardship in childhood. And we classified children into groups, or this method classified children into groups on the basis of their family's poverty status between 1968 and 1977. And so this figure displays item response probabilities for the measurement of the 4 classes that were identified of childhood economic hardship. And for each class of economic hardship, these probabilities indicate the proportion of children who were low income in each year. And so if we look at the bottom line there with the circles, approximately 64% of children were classified into this class that we called non-poor. So they had a very low probability of experiencing hardship throughout the period of observation. In contrast, represented by the line at the very top with the squares, children in the long-term poor class experienced a very high probability of exposure to economic hardship throughout the period, and about 18% of individuals fell into this class. And the other two classes, those moving into poverty, which is the line with the triangles, and those moving out of poverty, as you can see, experienced change in their status over time, their probability of experiencing hardship over time, and were differentiated by the direction of that change. And so children whose families moved out of poverty, that was about 8% of children, about 9.5% of children, experienced a high risk of poverty early in their lives, and then this risk dropped over time to relatively low levels by the end of the observation period. And in contrast, those moving into poverty began with a relatively lower risk, and that climbed steadily as they reached and began to transition into adolescence. So the classes of childhood economic environment not only provide us a picture of relative advantage and disadvantage, but they also capture other important life course concepts such as stability, change, and timing. And so next we did the same for the construction of health risk trajectories using repeated measures latent class analysis. And we used a series of repeated observations that were collected in the PSID between 1999, that was when the PSID started collecting detailed health information, and 2009, of 5 physician-diagnosed health conditions. And so these were heart disease, high blood pressure, diabetes, arthritis, and cancer. And so basically, respondents were coded 1 if they reported they were diagnosed with at least one condition in that survey wave. And so in the case of health risk trajectories, 3 classes were identified as the optimum fit for the data. And this figure plots the item response probabilities for these 3 groups of respondents with different experiences of health risk. So for example, for a respondent in the class we called low risk, which was about 59% of the sample, the probability of reporting a chronic disease in 1999 was about 0.05. And this remained the case until the last wave, as you can see where it ticked up slightly. In contrast, a respondent in what we called the increasing risk latent class, which was about 19% of respondents, had a probability of about 0.1 of reporting a health condition in 99, and that increased rather rapidly to end at about 0.84 in the last wave. And then finally, a respondent in the high-risk group, which was about 22% of the sample, began the period with a high probability of reporting a disease. So they experienced chronic disease quite early in midlife. So the health risk trajectories, again, also provide information on relative risk, and, health risk in terms of stability, change, and timing. So next we examined whether adult health risk trajectories differ for individuals based on their experience of childhood economic hardship, and in particular with an attention to whether timing and change in economic hardship in childhood is a factor in predicting membership in a particular health risk latent class. And so what you see in this chart are the odds ratios from a multinomial logistic regression predicting membership in latent classes of health risk trajectories. And the reference category in this model was the low-risk health trajectory. And so you can see the long-term poor latent class was identified by the red bars, and moving into poverty by the green bars, and moving out by the kind of purplish color bars. And we have a control for age included as well. And overall, it's clear that the long-term negative health effects of extended exposure to economic hardship they're evident here. They're easy to see. So if we take, for example, individuals who experienced long-term poverty and moved into poverty, they're much more likely to be in the increasing risk and the high-risk latent classes than in the low-risk latent class. For example, individuals who experienced long-term poverty in childhood were almost twice as likely as the non-poor to be in the high-risk latent class than the low risk, and they were over 60% more likely to be to fall into the increasing health risk latent class. The effects of changing poverty status on adult health are more complex. So overall, moving into poverty in childhood appears to be more detrimental to midlife health than moving out of poverty. Overall, we see those families who moved into poverty over the period were about 2.5 times more likely than the non-poor to be in the increasing risk latent class than the low risk, and they were 70% more likely to be in the high risk latent class. In contrast, individuals who moved out of poverty in childhood were as likely as the non-poor to experience a low risk health trajectory, so the difference there wasn't significant. Slightly different way of looking at this is through predicted probabilities, and so this chart shows predicted probabilities of belonging to each health risk latent class by childhood economic hardship class. And here we can see those in the long-term poor class have the highest predicted probability of experiencing a high-risk health trajectory. That's not surprising. For those whose families moved into poverty during their childhood, the predicted probability of experiencing an increasing risk of disease is twice as high as those who moved out. So it's 29% versus 14%, and the probability of being in the low health risk group is lower. However, their probability of experiencing a high-risk health trajectory is roughly equal to those moving out of poverty, so approximately 23%. So I wanted to talk for a moment about the challenges / limitations, and also the potential that taking this approach brings to the study of health over the life course and health inequality. And there are a number of challenges. I'm going to focus just on a couple because I could probably talk for the rest of the session about them. But one of the biggest, one that we found most important is that in this analysis, we're only examining conditions in early life. And so we risk what's been called a time one encapsulation problem. So basically, that's the risk of overemphasizing one's starting position by leaving out the interim social context. And for this analysis, we aren't testing competing models, like much of the literature, of the relative contribution of resources across various points or periods of the life course. So there's been much attention to whether it's the earliest points in childhood versus adolescence that carry the most weight, or our childhood context overall versus adulthood resources in adulthood that matter for later life health. Here we're focused on describing how adult health is really anchored in early life trajectories of relative advantage and disadvantage, and how the stability of that matters. Another concern that's relevant for any longitudinal analysis, of course, is panel attrition, because social disadvantage shapes the composition of a cohort over the life course. And an advantage we have using the panel study of income dynamics is that we have information on our respondents beginning in childhood, and so we have the potential to investigate selection processes that occur over the life course, which is interesting in and of itself, in addition to understanding how it's impacting findings. And so from our examination of changes in sample composition, we determined that attrition potentially weakens the effects that we find, but didn't bias the relationships that we observed in the analysis. But as we proceed with our analysis, and I had hoped to have some of these results ready for the conference and didn't have a chance to get them together, but we want to add in information from parents, about parents, and their health conditions that they experience when they were in mid and later life. And so as we do that, we're going to face additional challenges with regard to attrition, and we'll have to see how that limits the possibilities of using these methods. So overall, we were particularly interested in taking an approach that problematized heterogeneity within a population and could address questions, such as how differences in the timing or change in individual experiences are associated with health. And our study really advocates, we think, for moving toward thinking more about the entire individual life course as a dynamic trajectory, and identifying and understanding how variations in socioeconomic pathways are associated with patterns of changing health with age. And so a shift in focus and method helps us to address questions like, what are the health consequences of upward or downward mobility? And to what extent does the timing and the degree of this mobility matter? And influences on health also likely extend beyond the level of resources that we have available at any particular segment of the life course to the stability of those resources and the timing or changes in resources and the degree and the direction of that change. So these are some of the next steps that we're looking forward to tackling. And these influences can, of course, be very important, have very important implications for policy interventions and knowing when and where to target individuals in the life course. So we think this analysis, which is fairly basic, shows that it's useful to continue to examine disaggregated trajectories and suggest that the dynamics of disadvantage and its relationship to health are really more complex than what can be captured by models that use measures of childhood circumstances at one point in time and rely on those to predict aggregate, more normative changes in health over time. So thanks, and I welcome your questions.